only one who knows Tracy, but she's the palliative care coordinator over at the VA. Very knowledgeable. So we're all excited for her. All right.
So thank you so much, and I welcome any questions. I intentionally left this presentation pretty short so that we could have an opportunity for any and all questions or concerns or comments that you have at the end. So yes, I do know Ben and Catherine, and I am a nurse practitioner at the VA hospital, and I work out of our West Haven campus. And I've been at the VA for over 30 years, so I spent my entire professional career within the walls of the VA, first as a nurse and then as a nurse practitioner, and have a background in geriatrics, but transitioned full-time to palliative care around 2010 and have been doing that exclusively since that time. And so I have the wonderful opportunity to be able to be a palliative care provider in our ALS clinic here in West Haven. And that's unfortunately pretty rare because there's not that many of us that do this specialty, and it's really hard to get this in the community in an outpatient setting. So just a little bit about me. So as I said, I'm a palliative care nurse practitioner. I've been at the VA since the dawn of time. I really started when I was 5. I do have children that are over 18, so I'm not that young. And I started here on our long-term care unit as a staff nurse, then worked in the intensive care unit as a staff nurse. So I really have a sense in the hospital setting of all the levels and trajectories of care in the hospital. And I provide palliative care to veterans in all locations and all care settings, as does everyone on our team here. And that means that if one of our patients that I'm taking care of is admitted to the hospital, I see them in that setting. If they show up in the ER, I see them in that setting. If I need to follow them on the telephone, I'll call them on the telephone. If we need to do a video, we do a video. So we really try to deliver care in all care settings, but using all the technology that we have, whether it's an in-person visit, a video visit, or a telephone visit. And I have the pleasure and honor of participating in our VA Connecticut ALS Multidisciplinary Clinic, which is an ALS certified center of excellence and one of the few within VA facilities across the country. And as you I'm sure all know, that Hospital for Special Care, which is our sort of non-VA partner in Connecticut, is also a certified center of excellence in Connecticut. So it really makes me happy to know that we do have an extra layer of expertise across the state to provide care to persons living with ALS, whether or not they're veterans. And I also am the co-lead for palliative care in VISN 1 or VA New England, which means I oversee all of the teams in New England, all 8 facilities within our network, delivering palliative care to make sure that within the VA system, we provide uniformity of palliative care throughout New England, and also work with other facilities throughout the country to transfer veterans in and out of Connecticut when the need arises, and in and out of New England when the need arises. So that's really exciting, and that's a newer role that I started within the last year. Next slide. So palliative care always seems to have a weird connotation to it. Some people think it's just hospice care. Some people want to change the name of it to supportive care. And it really gets confusing because it can, the confusion with the title palliative care can really deter people from accessing that type of support. And so basically it's specialized care for people with chronic, progressive, life-threatening, and or life-limiting illnesses. So ALS is an illness that is chronic progressive, and every veteran that I see at VA Connecticut enrolled in our ALS clinic gets a visit with palliative care. The way that we do it here is I'm just a member of the team. So just like you'll see your dietitian or your physical therapist, you'll see me on that team. Generally speaking, palliative care is delivered by a multidisciplinary group itself. So in our own team, we have another nurse practitioner, a physician, a social worker, a psychologist, and a part-time pharmacist. In our ALS clinic, we don't have all the other members of our team participating because we already have social work support, psychology support, PT, OT, nutrition, neurology, and so forth. So we really don't need those added members of our team, but they are available. And the reason why we have so many people involved in care of patients with ALS and just care of patients in general with chronic complex illness is because it really takes a full team of people, a full network of people to help make sure that we're delivering the best possible care. And the reason why it's important to have different people is we all have different areas of expertise and experience that helps us provide care to patients with tricky illnesses. And so I'm a symptom expert, and that means that I have specialized training and expertise in dealing with very difficult to manage symptoms like pain and respiratory compromise and those sorts of symptoms. Next slide. So are palliative and hospice the same? Absolutely not. I often describe palliative care like a big pizza pie or a big umbrella with multiple spokes. And so one of those spokes might be facilitating home care support, and one of those spokes might be managing shortness of breath, and one of those spokes might be helping to get a piece of equipment in place. And one of those spokes is hospice. It is part of what I do. My certification and credentialing is for palliative and hospice care. That's a part of what I do, but it's not the sum total of what I do. And hospice is really specific to people at the very end of their life, and palliative care can be delivered at any point in a complex disease trajectory. And there's probably a 25 to 30% number of patients that we see in palliative care that we see for a while, and then we discharge from our program because they're doing so well. So this is really for people in a tricky health situation where they might be in the intensive care unit with threat of serious illness. They may be going through a really complicated cancer treatment, or they may be living with a chronic progressive disease like lung failure or heart failure, ALS, or a very advanced cancer. And we try to meet patients where they're at geographically as well as emotionally. So I try to go to their care setting. That's why ALS multidisciplinary clinics like what HSC has and what we have here at the VA work really well, because the team is there and the patients are and their families and their social support is at the center of that visit. And we sort of come and go, but the patient is that beacon that we work towards taking care of. And so palliative care coexists with curative treatments. And although ALS does not have a curative treatment specifically, our ALS patients may be undergoing clinical trials. They may be receiving disease-modifying therapies such as Radicava. And so we can coexist while all of those other clinical trials are ongoing, while those disease-modifying therapies are being given, because we're really trying to help a person live their best life despite having a chronic progressive illness. And as I mentioned, hospice is really dedicated to those persons in the last months of life. And so if someone we determine medically is in the last 6 months of their life or less, hospice is an added benefit that can help with transitions of care when people may be in that period of their disease. Next slide. So what types of symptoms can we help out with? So this is really general symptom management. So pain management. So not only have all of us that are prescribers have had specialty certification in dealing with pain management, we've also had specialized training in risk management, addiction medicine, and those sorts of things, so that we help when we do need specialized medications for symptom relief, that we've had the best and most up-to-date training that we possibly can have. We help out with other physical symptoms, nausea, shortness of breath, constipation, and so forth. We help out with psychological symptoms like anxiety and depression, which is certainly more prevalent in the veteran population. We also help out with post-traumatic stress disorder and those sorts of symptoms that may be more common in a veteran patient population. We also help out with social support. So if somebody was the breadwinner and is not able to work anymore, if somebody is having housing issues or food insecurity, those are the sorts of things that our social worker on our team is going to really be working on to help patients as best as possible. We also work and partner with our chaplains in our facility, as well as partners in the community of different faiths, so that if a person is having a spiritual need or a spiritual aspect of their suffering and coping with their illness, we can tap into VA and non-VA community resources to help people as best as we can. Next slide. So what do I deal with most commonly in ALS? So my early most common symptoms really are excess saliva and weight loss. And we work in partner with other people on our team to help manage these symptoms. So we work with our speech and language pathologists to work on excess saliva. So excess saliva can make it really uncomfortable for our patients. It can be something that causes them to be more isolative if they feel like this is happening when they're in public. It can be harder, especially for those that have speaking symptoms, to speak clearly when there's excess saliva in the mouth. And there's medications that we do utilize with some efficacy that help with alleviation of some of that saliva. And we actually partnered with our radiation oncologist at Yale, our partner facility for the VA, who has created, based on community research, national and international research, on salvage salivary gland radiation. So if saliva becomes so severe that it's affecting a person's quality of life and they have failed medication trials, we've actually referred patients for salivary gland radiation. So radiation that damages part of the response of the salivary gland and reduces saliva management by up to 60%. And so we've really worked hard to create a model for that here in Connecticut that has been demonstrated to be effective in ALS patients with saliva issues across the country. So weight loss, this is a multifaceted symptom that is one of the most common symptoms. So ALS is a wasting illness in terms of nutrition. It causes people to lose weight even if they're eating normally and consuming the same amount of calories they did years ago. And I see the same thing in folks living with cancer as well. So it's something that I'm quite familiar with. And we really partner with our dietitians, with our speech and language therapists, to help people with weight loss and to have open and honest conversations about nutritional supplements, feeding tubes, and those sorts of interventions to help people, again, manage their weight loss in a way that seems most consistent with their goals and their values. As ALS progresses, shortness of breath becomes a more prominent symptom, and right along with that, anxiety related to shortness of breath. And so shortness of breath and anxiety are somewhat of a continuous circle, or a vicious cycle, if you will, where if somebody gets nervous, they may be more short of breath. If they get short of breath, they may be nervous. Working with our psychologists in clinic to help break that cycle, working on cognitive behavioral therapies, meditation, and other trainings to help with non-medication management. We also we use non-invasive respiratory support, the masks that you probably are familiar with, to help breathing symptoms. We use medications to manage anxiety, and we also use medications to manage shortness of breath. And both of those medications are quite effective at reducing symptoms and helping people, again, live their best life with this illness. Next slide. So when should palliative care start? So palliative care can start at any time, but I think with a chronic progressive illness such as ALS, it should start as soon as possible after diagnosis. That's certainly because it's really helpful to get a baseline of where somebody's starting at, what they understand about their illness, what symptoms they're already dealing with that are interrupting their best comfort level. And in our clinic, if I don't meet a patient at the very first visit with our clinic, they are met at the second visit. And the only reason I wouldn't meet them at the first visit is if the person is just too exhausted by the end of meeting all different providers, that it just becomes more taxing and less beneficial. But I try to meet patients at their very first or second visit, and I see them just like every other team member at every single visit. And when people are in a later phase of their disease and are having many more symptoms, often in addition to their They're every 3-month regular visits. I'm calling them in between every 2 weeks, every 3 weeks, every month. Just this morning, I spoke with 2 patients in our clinic because of symptom management needs. And I booked them for calls, 1 in 3 weeks and 1 in 4 weeks, because they need that sort of support along the way. I am the person that I hope that the clinic patients identify as ones that can be asked any question about anything in their life that's interrupting their ability to feel as good as possible. That may be talking about legacy work. It may be about taking a trip. It may be about maintaining intimacy with their partner. I really try to create an environment where people feel that they can ask a question that's weighing on them to help them live as good as possible. And to be, somebody in our program that the patients and families know that they can go to. Because I did have a situation a few years ago when I said something casual like, hey, if you've got an elephant in the room question, please ask me. And a family member asked about what would happen if a certain symptom presented itself. And we talked through what we would do if that symptom was. And it's been several years. I don't quite remember what the exact symptom was. But the person said that they had been this was a spouse of a patient, that they had been staying up for nights worrying about that symptom. And they just didn't know who to turn to and who to ask. And I think that's true of anybody in your ALS clinics, any of the providers in your team, any of the team members. They all share my sentiments that if you have a question that's keeping you up at night, that you want answered, ask and you shall get an answer. And if we don't know the answer, we will find out the answer or figure out how to get it to you, because we don't want you to have unanswered questions that could help you live as good as possible. And I think it's really important, and one of the mainstays of our program that's not specific to our ALS clinic or the ALS clinic that I work with. It's really specific to how palliative care is delivered at our facility. We follow patients along the trajectory of their illness. We want to know them as soon as possible. We don't care where we meet them. If they come into the ER, we're probably going to find them there. We want to be available in all care settings, because it can be scary to be in the hospital, especially with an illness that might have robbed you of your ability to communicate readily with others, so that we can help communicate your needs, communicate your values to the medical team taking care of you in that setting. We even have a tablet on the desk over there. A family donated back to us, and we have another patient, not with ALS, but another patient that's having communication issues, that my colleague is running up to the ICU to deliver a tablet so they can communicate with their care team, because it's very destabilizing for them not to be able to get their needs met when they can't communicate verbally. And so the longer we know our patients, the better we know our patients, the longer we know our family members and social support and community supports for the patients that we are honored to take care of, the better that we can take care of them. Next slide. So what do I talk with my veterans the most about? So symptoms come up all the time. When I'm coming to check in with, some of our most, quote, boring patients, and certain people will know who I'm talking about, I always want to make sure that I'm not missing out on new symptoms that might be going on. I try to check in with them socially and just chat about what's going on in their life and things that are important to them. That may seem a little informal, but it's the best way that I can get to know my patients over time. I try to figure out if there is a time that services that could be of help, putting in a home care support, identifying community resources. And this is something that every member of our team does. It's very much not unique to me in that clinic. Is there a piece of equipment that I think you might benefit from? I'm going to be scurrying to our occupational therapist or a physical therapist or a speech therapist to say, hey, is this something that you guys have thought about? They probably have already done it and ordered it, and it's already in the home before I even think about it. But again, the more people that are thinking about these things, the more resources patients are getting in real time that can benefit them. And I do talk about tough subjects. So sometimes I chit chat with my patients and we share funny stories. And sometimes I talk to them about really scary stuff, like that they're losing weight and I'm worried about them, or that they had a pneumonia because they didn't swallow well, or that their breathing is getting worse despite their mask support. And find out what's important to them and help align whatever we're doing medically to what their wishes are and values are as things change with their illness. And I won't shy away from these topics because I feel it's a patient's right to have their voice heard, even when they can't speak out loud, to make sure that whatever we're doing medically is consistent with what they want us to do. Next slide. So what other things do palliative care providers talk about? So this is not specific to ALS, it's for any patient in any setting that I see. So advanced care planning, this is something our social workers really do. How do you make sure that your medical care is consistent with your wishes and values? Who do you want to be your spokesperson? Is that person the best person to be your spokesperson? Sometimes the spokesperson is not the person that's closest to you emotionally, because it may be too hard for that person to take on that role. Maybe it's somebody that is just more kind of matter-of-fact person in your life that has kind of less emotion about things. And make sure that gets documented early. Make sure that gets reviewed on a regular basis. Wishes change over time. As someone adjusts to their illness, they may find a medical intervention more acceptable than they found earlier in their disease course. And that's what I talk to patients about. Goals of care. What are your care goals? Are those feasible? If you want to be at home, is that something that we can accomplish? Or do you have 17 flights of stairs to walk up? And do we need to think about that early to get you into a more suitable location where you can get your care received? Coordinating care across settings. So again, this is something our social worker in the clinic really does, Tina. So she works with our case manager and she works with our transfer coordinator, because our patients travel far sometimes to come to us. And if they get sick, they may not end up at our facility. They may end up at a hospital close to home. Our neurologist has reached out to community medical facilities and talked to the providers taking care of our patients that end up in a different hospital to make sure that they know that they're connected with our hospital, that there's a team of people that know them, that work well with them, that we can get in contact with. And then helping along with our case managers at arranging for home care referrals or any equipment needs that I would confer with my OT and PT providers about. Next slide. So how do I get palliative care? So if you're in a big medical facility, if you're at Yale, if you're at Harvard Hospital, Bridgeport, if you're at a big medical facility, they will have a palliative care team there for you. At a smaller hospital, at a rural hospital, that may be harder to find. In an outpatient clinic, that may be harder to find. But anyone can deliver what I do. There are some aspects of what I do that are pretty tricky. Severe complex pain is a pretty tricky symptom that not everyone feels comfortable with. But the things that I'm talking about, managing saliva, managing shortness of breath, talking to patients about wishes and values, that's not fancy, that's not rocket science. That's something any provider can talk to you about. And that's what's called primary palliative care, which means you don't have to have somebody like me. I mean, I love to take care of everybody. I love the work that I do. But palliative care is a small field. It's a new field. There's not a lot of us out there. But primary palliative care has existed forever and will exist forever. And that's people in your own clinic, in your own primary care provider, your own medical facility, asking for things that are important to you, telling your providers that you're having uncontrolled saliva or you're getting short of breath despite your BiPAP support, your non-invasive support, telling your provider that you want to talk about future planning, advocating for yourself or your family member for home care support. So that's primary palliative care. You shouldn't need somebody with a lot of extra initials to get the care that you need at the place that you need at the time that you need. And in Connecticut, we are lucky because we do have something that a lot of other states do not offer, and that's called home palliative care. And so that's offered by skilled nursing agencies. In Connecticut, we have over, I think, somewhere around 30 skilled nursing agencies, and some of them provide something called home palliative care. So it's somebody with a nursing background that has similar experience like I do, or like our social worker does, or a physician does, in helping out with symptom management. And if symptoms are becoming trickier and you don't have access to a palliative care provider in your clinic and you need some extra support, that's something to ask your case manager, your social worker to get that support. And it does exist in Connecticut, but a lot of people don't know it exists or how to access or ask for it. Next slide. So this is just what I was speaking of previous, but types of palliative care. So primary palliative care, anybody can help with symptom management. Anyone in your clinic can help manage goals of care. And specialty palliative care is what I do. It's experts in palliative care that have received specialized training in this field of medicine, and it's usually available in larger medical centers. Simply because there's not a lot of us. We don't make money for a hospital, so there's not a lot of incentive to hire more of us. So pretty much teams are pretty small. At least once a day, I get a call from somebody asking if I'm the person on for palliative care. It's been like 15 years. I've never been off for palliative care. I don't know what that is. There's big teams like cardiology. There's, all these people to choose from. You always get a new person every week. We don't have that. It doesn't exist. I don't understand what that is. I don't know what it looks like. So we're always sort of on because there's not that many of us. But in this field, and I've met people within the VA and outside the VA and nationally, regionally, and it's just a field of shared love for taking care of people with complex illness. And we're all kind of built the same and think the same and have similar passion for this type of work. So we are out there. Next slide. And so I think I mentioned this earlier, but I think it bears repeating. So how do I advocate for myself as the person living with this disease? Ask your provider if they have an ALS program, if they have a palliative care program. And again, in hospital settings, you will find this. In outpatient clinics, it can be harder. Advocate for yourself by reporting new symptoms that are bothering you. We may forget to ask about a certain symptom that's really been nagging at you. I always ask about things like breathing and appetite, weight. I may forget to ask about constipation or nausea, for instance. So tell us about symptoms that are not comfortable, that are bothering you, and that we're not asking about. And this is the most important thing I think I could say. Ask all questions that weigh on you. Ask anything that weighs on you. We don't know what's in your head. We don't know what's weighing on you. We don't know what's concerning you. And we can help to alleviate concerns. Even when I have to share not great information, a lot of patients will tell me that it's better than the unknown, better than not knowing, better than creating a narrative that, a story in their own head about how something's going to look, rather than have a plan and receive reassurance and support and guidance. Next slide. That's it. So I love working with my veterans with ALS. I love working with veterans in general. That's why I'm here for so long. I'm not a veteran myself, but I just love the veteran patients. They're a wonderful, interesting group of people. We do have more men than women. So, in the grand scheme of things, Ben is not outnumbered in our clinic for sure. But I just love it so much. I love working with veterans in general. And I just find it really being part of an ALS clinic with all people from all different specialties who are so dedicated to this work is really inspiring. I've had an opportunity to meet, several people along the way at Hospital for Special Care and participate in a national conference and really meet people nationally that do this work. Work with patients living with ALS, and it's just a really wonderful group to work with. Everybody's so willing to share with everyone else, and so thank you. So I don't know if folks have questions. Feel free to speak up, come on mic, do